Good evening, everyone. We'll start with a word of prayer. Dear Heavenly Father, we thank you for giving us the opportunity to gather to impart knowledge upon our patients, and we ask for a very productive and informative session this evening. In your Son, Jesus' name we pray. Amen. 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 Good evening, everyone. It is my esteemed pleasure to welcome you all to today's live webinar on menopause, a topic that is deeply important and often overshadowed. Although it affects half of the world's population at some point in their lives. Today's webinar serves as a launchpad for our highly anticipated Renew Clinic, which aims to restore, empower, nurture, and promote wellness among women. Whether you are here as a healthcare professional or someone going through the menopausal transition, a caregiver, or simply eager to learn, we are elated that you have joined us. For far too long, menopause has been concealed in stigma and silence, but not anymore. We are here to change that and bring normalcy to the conversation through sharing reliable information, exploring management strategies, and ensuring that no one feels alone on this journey. This evening, we will hear from a distinguished panel of experts who will navigate us through the physical, the emotional, and social aspects of menopause. There will also be time for questions and interaction, so we encourage you to engage and make the most of this opportunity. Without further ado, I would like to welcome our moderator for this evening, internal medicine specialist, Dr. Amala O'Black. Dr. O'Black.
Thank you. Good afternoon, everyone. And thank you very much to you, our viewers, for joining us. Thank you to our sponsors, Doctors Hospital, for arranging this wonderful meeting. So we get started, and we welcome you to the Renew Clinic. And yes, we talk about menopause today, but the Renew Clinic will help not just women, but men navigate diseases and stay healthy on this journey of life. Try to get the next slide coming to you. And so we have here just an agenda of what you can expect today. And Dr. Vashti Darling already alluded to it, but we have an expert panel of speakers. We have Dr. Rand, who will be talking about the cardiovascular risk factors during menopause. Dr. Ariana Davis-Simmons will talk about the treatment modalities for menopause. Dr. Dorita Francis Phillips will discuss gynecological symptoms, treatment, and sexual health. And Dr. Saeed Abo, complicated gynecological issues of menopause. Dr. S. Hutchison will discuss how menopause affects you psychologically. And Dr. J. Martin will discuss healthy lifestyle habits and menopause. So a wide range of topics. And I'm sure most of you out there thinking, I did not realize menopause encompassed all these different aspects of my health. We'll have some time for questions and some closing remarks from our Executive Director of Patient Services. There you go. So our clicker is in business. And so just to get started, what is the perimenopause? The perimenopause is that period of time before your periods start. It generally will happen 7 to 10 years before the menopause. Most women will go through the menopause between ages 51 to 55. It is, however, not unusual to have some women go through perimenopause much earlier in life in their late 30s. I'm not going to spend too much time on that because we have all our gynecology specialists, but I just wanted to set the stage for today's discussion. Menopause being that time after you no longer had a period for 12 months, then you become postmenopausal. Menopause is not a disease. Menopause is a natural part of aging, and it happens as a woman starts losing her hormones that cause pregnancy, estrogen and progesterone. It can affect all the systems in our bodies, this low estrogen. It can affect the brain, the heart, the bones, the muscles, some of which we'll discuss a little bit later. The symptoms of menopause are different for each woman. So we are not all going to experience the same symptoms, and we're not going to experience it in the same time frame. But what is important is to understand that it exists and to understand that we have to be there for each other, not just as women, but also as partners, husbands, boyfriends, family members, friends. I also want to highlight that, the perimenopause, the menopause tends to happen in the 4th and 5th decade of life. But this is also the time that chronic non-communicable diseases tend to present. These diseases being high blood pressure, diabetes, high cholesterol, which also increase your risk for cardiac disease. And cardiac disease or heart disease is still the #1 cause of death in both men and women, not just around the world, but here in the Bahamas. During this perimenopause is often a time when women find themselves doctor shopping, going from doctor to doctor, trying to figure out what is wrong with them. They have shortness of breath, palpitations, feel weary, experience brain fog. A lot of women also start thinking that they're losing their memory. They come to the doctor saying, I think I'm getting dementia. Women come complaining of weight gain, wanting hormonal tests, saying, I haven't changed how I eat, I'm eating more healthy, I'm exercising, but still gaining weight. And so they find themselves going from doctor to doctor, trying to figure out what is going on with me. And so in that vein, we really want to encourage not just patients, women, everyone, to educate themselves on what is the menopause, what happens in the perimenopause, what to expect. But it's also important for physicians to educate themselves, do continuing education. Because when you start delving into menopause and how to treat menopause, a lot of physicians will tell you, we were not really taught menopause in school other than it's a part of the physiology and what happens with women. We did not really get detailed training on how it affects a woman's life, how can we help her, what to look for, and what are some of the complications that come with menopause. And so menopause essentially happens, like I said before, when the body stops or decreases the production of estrogen and progesterone. And I want to say here that estrogen and progesterone, we had our whole entire life. And so when you get to age 45 and this hormone starts dropping, it's like a withdrawal of sorts. And that's what causes a lot of the symptoms that we experience. The low estrogen has a significant impact on our bone health. The low estrogen causes demineralization of the bones or weakness in the bones, and this is why we get osteoporosis. This is why women over the age of 65 are more prone to fractures. And treating menopause early and the perimenopause can decrease bone fractures and osteoporosis. Cardiac health. The low estrogen causes thickening of our blood vessels, and often that's why we see high blood pressure in this age group. The low estrogen also has an impact on our cholesterol. Our cholesterol goes up because estrogen plays a role in keeping our cholesterol lower. And as a result, women get more heart attacks in the postmenopausal period versus in the premenopausal period. And we have Dr. Ran who will be talking about cardiac health and menopause. Brain function. Every single organ in our body requires estrogen, including the brain. The brain actually requires a high amount of estrogen. And as this estrogen drops, women notice brain fog, word finding difficulties, talking in the middle of a sentence, you've forgotten what you wanted to say. You know exactly why you know the person, you know everything about the person, but the name just isn't coming to you. This can actually go on to some women developing dementia later in life. And this brain fog, this feeling of forgetfulness, often forces a lot of women to lose confidence in themselves in the workplace and even leave their jobs. So, it's a really big issue for women. We talked about the osteoporosis. I'm not going to delve too much into the emotional or psychological behaviors because we have Dr. Hutchinson with us today. But I do want to say that a lot of women will come in complaining of being irritable, being upset, having, rage and not understanding why. Women spend approximately 30% of their lifetime in this postmenopausal period. That's almost 1/3 of our lives. 1/3 of our lives trying to understand what is going on. Why do I feel this way? Why am I aging so quickly? Why am I so tired? Why am I forgetting? This is not something to be taken lightly, and women deserve to understand more about menopause and what they can do about the menopause. For some women, it's very easy. So you'll meet that woman that says, I had absolutely no problems, walk in the park. And then other women, that felt their life was falling apart, they hide away, and their whole lives change. Families fall apart. And again, this is just to highlight the medical complications. We've gone through most of these already. From my perspective, internal medicine, I just want to again highlight, this is when high blood pressure, cholesterol, diabetes often presents, weight gain, especially around the midsection. A lot of women come in complaining of that. That is very, very characteristic of menopause. As we lose our estrogen, we get a redistribution of fat from our thighs into our waist area. But unfortunately, that fat distributes around our organs, the visceral tissues in the body. And that is what leads to diabetes, high blood pressure, and high cholesterol. Musculoskeletal pain. A lot of women in their 50s end up getting a diagnosis of frozen shoulder. This frozen shoulder is related to the inflammation caused by the low estrogen, sinus disease, shortness of breath, asthma-like symptoms, itching in the ears, itching all over the skin, dry hair, change in the texture of the hair loss, hot flashes, depression, anxiety, dry eyes, sexual dysfunction, which we will have a talk about during the course of this symposium. Most of these symptoms I've already discussed, but I'll just say some of them that we haven't said: bloating, irregular heartbeat, panic attacks, allergies, headaches, electrical shock-like feelings, tingling in the fingers, tingling in the toes, breast soreness, burning mouth syndrome. This is a very real one. Dental issues, because of the dryness, dry eyes, dry mouth, dry vagina. The dry mouth increases your risk for tooth loss, tooth disease, gum disease. The dry vagina increases the risk of urinary tract infections. And dizziness. A lot of people actually come in complaining of feeling very tired and dizzy all the time. So, as an internal medicine specialist and also family practice, we find that these women come into us before the periods actually stop. They come in complaining of a lot of these symptoms we discussed. This is the time that we should be screening these patients for diabetes, high blood pressure, high cholesterol, to try and reverse these chronic diseases and prevent cardiac disease later in life. Obesity education and referral to the dietitian, the exercise therapist, screening for mental health and dementia, giving the patients tools to improve their mental health and also reduce dementia, as well as teaching patients about the importance of education on the impact of low estrogen on our bodies, on bone health, what we can do. So, there's a lot that we could talk about menopause. It's not just, I no longer have a period and I can't have babies. It affects every single part of a woman's body and affects every part of her life. What are some of the treatment options we have? I'm just going to read them because we have all our specialists here that will discuss them. We have our non-hormonal therapies, we have diet, we have exercise, weight management, we have evaluation and treating your cardiovascular diseases, psychological therapies, and then of course we have prescription medications. I'm not going to discuss the prescription medications because a lot of these medications you'll discuss with your visit with your internist, your family practice physician, your gynecologist. And then we have hormone replacement therapy, which has been the dreaded treatment that everyone fears. And we have our gynecologist here who will help debunk some of those myths. So I just put this here for our audience, in case you wanted to go and do some investigation on your own, these are some of the reputable menopause websites you can go to. There is patient information, there's doctor information, and there's also research guided evidence in terms of what therapies we should use. And so, on that note, with the introduction of menopause, we move to our second speaker, who's going to be Dr. Saida Bo, gynecologist, oncologist, and she is going to discuss complicated gynecological issues of menopause.
Good night to all, and let me see if I can start sharing my screen. Okay, is everybody seeing my screen? Okay, so I've been tasked with talking about menopause and cancer, which is a very interesting and big topic. So somewhat of an overview or repeat of that which Dr. Ablak just mentioned, discussing cancers after menopause, and then there's menopause after cancer. So something that we don't commonly talk about, menopause after cancer, because at times there are young women that have a cancer diagnosis, and due to their treatment that they received for their cancer, they then are sent into menopause. How do these women now navigate that space? So menopause is not associated with an increased cancer risk. However, cancer rates increase with age. So as Dr. Black said, most women spend about 20-25% of their lives in menopause. And as you age, your risk for a cancer diagnosis increases, unfortunately. And cancer, as we know, is the second leading cause of death worldwide in women. Breast cancer being most times one of the most common gynecologic cancer diagnoses. So what are the most common cancers after menopause? As I said, breast cancer, uterine or endometrial cancer. Endometrial cancer is also one of those common diagnoses after menopause. This is a diagnosis that is made as a result of a woman presenting with postmenopausal bleeding. So just want to take a second to talk about this. Women normally say that they're menopausal because they realize that there's an absence of their menses. Yes, once you've gone 365 days without a period, then you've now reached menopause. But menopause is more than just the absence of your menses. You do bleed after you've gone through menopause, then this is now called postmenopausal bleeding, and this should be investigated. Because one of the things that we are very much so concerned about is whether or not you have a cancer diagnosis. This cancer can have a very good outcome once it is diagnosed at an early stage. Unfortunately, there's a lot of misconceptions, and a lot of persons have the understanding that I should have a period again once, or I should have a bleed after I've gone through menopause. And I just want to highlight that you should not have a bleed once you've gone through menopause, because the average age of menopause is about 50 to 55. And so once you've gotten to that age and you have gone through menopause, you should not bleed. Now, if this is a younger lady and she's gone through premature menopause, or you've gone through menopause at an early age and you do bleed, then yes, you still should also seek medical attention for this. The other cancers that you can see after menopause would be your ovarian cancers, cervical cancer, and vulva cancer. Again, they're all related to age. So in terms of cervix cancer, we know that cervix cancer, there's peaks when women can be diagnosed with this. It peaks at around the ages of 35 to 45, and again, in the menopausal patient. between the ages of 75 to 85. Your pap smear, again, is the most accurate way of diagnosing somebody with cervix cancer, and this should be done every 3 years. We do recommend stopping screening at the age of 65, and that is with the advice that you've had normal pap smears for the last 10 years. So if your last few pap smears were normal, then you can stop screening at the age of 65. It does not stop you from being seen by your family medicine physician, your gynecologist, and just having a pelvic examination, because again, something could be there that we will now be able to diagnose for you. Vulvar cancer, again, this is also something that increases as a result of age and not really a diagnosis that was commonly seen in the younger population. It's more patients that may have some sort of vulval lesions that most times patients just think that, oh, it's nothing of significance and it will go away. Well, watch it, and if you see that it is increasing in size, then I would suggest that you do seek medical attention. So the other, I don't want to say big topic, but the other area of concern is menopause after cancer. As I mentioned, a lot of young women are being diagnosed with cancer, whether it is breast cancer, ovarian cancer, or even uterine cancer, because there are a few young patients that have a diagnosis of uterine cancer and colon cancer. So any cancer that can be in the pelvic region or cancers that may have intense treatment can result in a person going into premature menopause. With cancer treatment, about 40% of women under the age of 40 will end up into menopause. 70–90% of these women sometimes end up into permanent menopause, and that's as a result of their treatment that they received. So the treatments, as we know, can be that of chemotherapy, and depending on the chemotherapeutic agents used, they can be very strong and result in a person having permanent menopause. Some patients, when they are on chemo, may have that they do stop seeing their periods, but then after a few months of no longer receiving chemotherapy agents, then they may have a resumption of their menses. That is also normal, but again, it would depend on the chemo that you're receiving. Then again, now you have radiotherapy that may be given. So in somebody that may have a cancer in the pelvic area as a result of endometrial cancer, if they have cervix cancer, or if they have vulvar cancer, or even colon cancer, they receive radiation treatment. Because of the radiation that they would have received, it will then adversely affect your ovaries, then putting you into premature menopause. Also, again, now because of surgery can also result in you going into menopause. So somebody that may have a diagnosis of ovarian cancer, both ovaries may be removed at the time of your surgery. And if your ovaries are removed, then that's an immediate menopause. And those symptoms that patients would experience, again, would be different than if this is somebody that has gone gradually through menopause. And in preparing for this, I've seen that a lot of persons with this diagnosis of cancer who then go into menopause, they feel unheard. They've been dealing with a lot because they've dealt with the diagnosis of cancer, and then now they're being placed into menopause. And I just want to say that there are treatment options available for persons who've gone into menopause as a result of cancer. So if it is that your cancer is hormone receptor sensitive, if somebody with a breast cancer diagnosis, then there are other treatment options. And I'm sure my esteemed colleague, Dr. Francis Phillips, will talk about those other treatment options for persons who cannot receive hormone replacement therapy. But there are treatment options, and you should not have to not navigate this space without seeking medical attention. So I just want to end by saying menopause matters. Let's talk. Thank you all.
Thank you very much, Dr. Bo. And so again, we have a time for question and answers at the end, so you can start putting your questions in. We move to our second speaker. Our second speaker is Dr. Elias Ran, and he's a general and interventional cardiologist. And he will be discussing the cardiovascular risk factors during menopause.
Thank you, ladies and, well, ladies and gentlemen. Let me start by saying this is such an amazing opportunity and such an amazing project to be part of. An important initiative because this is one of these subjects that we don't talk about enough, and me as a cardiologist tend to see in clinics and on our daily routine quite a lot. There are a lot of concerns and a lot of questions, and unfortunately, not a lot of answers from the medical community. And these highly specialized clinics are lacking, and unfortunately, we tend to miss out a great part of our patients for that reason. So I'll just my name is Dr. Ran Elias. I work at Doctors Hospital. I'm an interventional cardiologist, and I'll just dive into the topic of menopause and the heart. Probably start by saying you are unique. Women are unique for many reasons. Your body goes through transformations throughout your life. You carry life inside you. You go through a lot of hormonal changes and a lot of extreme physical changes that put very high stress and load on the body. And all these factors combined, well, first of all, make you amazing. And second of all, sometimes lead to progression of disease and sometimes lead to other medical conditions that our job is to diagnose and treat. Some baseline definitions. So we talk about peri or pre-menopause. We talk about menopause, and we talk about post-menopause. We talk about premature menopause when it happens in less than 40 years of age, and we talk about early menopause when it's usually less than 45 years of age. All these are important timelines. Now, interestingly, that compared with non-Hispanic white women, the Japanese American women may experience menopause at a later age, whereas Hispanic, Native Hawaiian, and Black women may experience menopause at a relatively younger age, as we said, less than 40. That's something to bear in mind. Now, the main cause is the hormonal changes and the symptoms that women experience, and the symptoms are many, as you can see from this graph here. And usually 85% of women will experience one or maybe even more of these symptoms. That might be anxiety, irritability, insomnia, depression, night sweats, hot flashes, sexual dysfunction, and more of those symptoms. Now, the stages of menopause, as I stated before, are respective and are caused mainly by hormonal changes. Noteworthy is the estrogen and progesterone levels that tend to decline steeply when women enter the perimenopausal phase, leading to a sharp decline and then to somewhat of stabilization throughout the postmenopausal stage. There's also some role of testosterone with a decrease and then a stabilization throughout this process. What about the effects on the cardiovascular system? We know that about 50% of women will experience menopausal heart palpitation, for example. Some will experience heart palpitation during hot flashes, the famous hot flashes. During a hot flash, what happens is the autonomic control of your heart rate is altered, it's changed. So you experience like racing in the chest, palpitations, together with the hot flashes, and that is the reason it happens. You might have night sweats, and those night sweats can also increase the heart rate and lead to a sensation of palpitations or pounding in the heart. And atrial fibrillation, which is a very big topic related to menopause too, might be prevalent during this period. Menopause and heart disease kind of go hand in hand, but it's probably important to understand that menopause by itself does not cause heart disease. It's usually the change in the hormonal levels and other risk factors that contribute to development of heart disease, like low estrogen levels, together with weight gain, smoking, family history of heart disease, and sometimes also the replacement therapy itself. And we'll probably talk about that if we still have time at the end. There are several lipid parameters that change during menopause: the total cholesterol, the LDL, which is the dangerous cholesterol, and the apolipoprotein B levels that might increase dramatically, leading to development of atherosclerosis, which is the disease that causes the narrowing and eventually the heart attacks that people suffer from, women suffer from. Cardiovascular disease is a leading cause of death in women after menopause. The risk of this disease, it steeply jumps, I'd say, after menopause. Women typically develop coronary heart disease several years later than men, so there's a lag period. The hypothesis is that menopause transition, the same hormonal changes, contributes to the increase in coronary heart disease risks. And that's because of the hormonal changes. But there are other factors that play a role here too. And this emphasizes the importance of monitoring and intervening early during these symptom development. The vasomotor symptoms, hot flashes, are quite common, about 80% midlife women. They can last for 10 years, which is a very long time. Factors related to higher currents and severity are obesity, smoking, anxiety, depression, and lower levels of education. Cardiovascular risk is also related to sleep disturbances, anxiety, and depression as well. Usually the vasomotor symptoms, the worse they are, so basically the more the cardiovascular risk is. So keep that in mind. What about menopausal hormone therapy, or HRT? So the beneficial effects usually occur if we start the therapy early, meaning when women are less than 60 years of age, and usually less than 10 years since the symptoms develop. Okay, bear that in mind. Okay, because there are harmful effects if we start this therapy when in women who are above the age of 60 or who have less than 10 years of symptoms. Okay, or have, sorry, more than 10 years of symptoms. Now, the evidence supports cardiovascular benefits for menopausal hormone therapy if it's initiated early. Okay, this is a very important point. Okay, so it's sometimes hard to judge whether or not we need to start therapy, but we have to bear in mind that the therapy should be started as soon as possible. Now, the benefits: they lower rates of diabetes, they reduce the insulin resistance, and they protect from bone loss. But above all, probably they relay some protection against development of atherosclerosis that was mentioned before, and ultimately heart disease. And with this, I think I would conclude. This was a short summary, but an important, very important topic, and there's much more to elaborate on this topic, and I think the clinic will do a great job in doing that. Again, thank you for bringing up this such an important topic, and thank you for letting me be a part of this, and looking forward to see you in the clinic. Have a good evening.
Thank you very much, Dr. Rand, for a very enlightening presentation. and highlighting the importance of taking care of our cardiac health during this menopausal time. And also thank you for highlighting the benefits of menopausal hormone replacement therapy when started, not just at an early age, but almost at any age in the prevention of cardiac disease. And now we move on to our next speaker, who is Dr. Ariane Davis-Simmons. And she is going to highlight for us the treatment modalities for menopause, indications and contraindications. Thank you very much, Dr. Davis-Simmons, and you can take it away.
All right. So I hope everyone can see my slides. So we're going to talk a little bit about, so we're going to talk a little bit about symptoms, which we kind of highlighted already. So I'll pass through that pretty quickly. And then we'll get to some management options. So we've already clearly defined what menopause is. It's a natural event. It is classified after a year after your final menstrual period. Normal ages occur between 40 and 58. And again, it's an important topic to talk about as women. We are aging, and we're going to spend 40% of our lives in that postmenopausal period. So we kind of highlighted what are the transitional stages through menopause, which is perimenopause, menopause, and postmenopause. What I wanted to highlight is that in perimenopause, a lot of the symptoms that we're going to talk about in menopause begin. It's a period of hormonal chaos. It occurs in the mid-40s. There's different depending on the data. It's between 4 to 6 years on average, but can last up to 7 to 10 years. So with perimenopause, there's actually no definitive testing. It is a clinical diagnosis. So if you're in the appropriate age and you're having symptoms, menstrual irregularity, you can start having hot flashes, mood disturbances, brain fog, aches and pains starting in that period. So then you should seek treatment by seeing your primary care doctor, your gynecologist, or your family med doc. So estrogen and progesterone receptors are everywhere. And this is why the symptoms are so vast and can be so profound, because a lot of organs have receptors for these hormones. So as they decline, we become symptomatic. So when we talk about symptoms, we're talking about hot flushes, night sweats, vaginal dryness, migraine, sleep disturbances, bladder problems. You can have weight gain, but in particular, it's more of a central weight gain. So it's a change in the way we gain weight. So it's more central adiposity. You can have crawly, itchy skin, changes in hair. We talked about some of the symptoms in terms of mood, anxious irritability, mood swings, and difficulty concentrating. So there is no kind of one menopause syndrome. Women all have their own journey. Even women in the same families may have different experiences and may experience perimenopause and menopause differently. As we highlighted, about 80% of women will be symptomatic through this transition. 60% will have mild to moderate symptoms, 20% will have severe symptoms, and there's a lucky 20% that'll have no symptoms at all. So when we talk about the vasomotor symptoms, this is the most common symptoms. It's going to be the hot flashing or the night sweats. You can have chills, anxiety, heart palpitations that accompany this. And the way it's described, it's a central rising heat from the chest that goes to the face and neck. And it can last anywhere between 30 seconds to 5 minutes. And this can happen multiple times throughout the day, and it can be very distressing for women, creating varying degrees of distress. So 80% of women will experience this through menopause. Some will even start to experience it in kind of the typical time you would think is premenopause time, also in the perimenopause, and about 42% will experience it, will have documented experience it throughout menopause. When we look at vasomotor symptoms, it actually varies depending on ethnicity. So African American women tend to experience for a longer duration, up to 10 years, Hispanic women up to 8 to 9 years, whereas our Caucasian counterparts experience it around 6.5 years, and Japanese and Chinese women experience it for the shorter duration. Unfortunately, about 10% of women can experience these vasomotor symptoms, as hot flashes, night sweats, for 20 years or more, and sometimes it never resolves. So I have a few patients where they're on estrogen, late into their 60s, 70s, because when they titrate off, they're very symptomatic. So other factors that affect vasomotor symptoms are going to be being obese, if you smoke, low socioeconomic class, low education, consuming a high-fat, high-sugar diet. We talked about, being Black and Hispanic ethnicity puts you at risk. Women who've had surgical menopause, so when they've had their ovaries removed, that is a risk factor, obviously, for having very violent and prominent vasomotor symptoms. And also patients who have thyroid disease, diabetes, OSA, chronic pain syndromes, have anxiety, they tend to experience worsening hot flashes and night sweats. So I'm going to kind of skim over this because I know my colleague, Dr. Dorita Phillips, is going to talk about sexual health and genitourinary symptoms. But the lack of estrogen also has an effect at the vagina. It can result in dryness, dysuria, urinary frequency, and can lead to difficulties with sex, delayed orgasm, and painful intercourse. And large amounts of women, so up to 50% of women, can experience these symptoms through the menopausal transition. And unlike vasomotor symptoms of the flashes and the night sweats that tend to get better as you transition and navigate through menopause, these symptoms tend to get worse. So sleep disturbances is a big symptom that we see in patients with menopause. It can start in the perimenopausal period. It can present just with difficulty sleeping, or can be more profound, like insomnia. This may be due to kind of night sweats causing the sleep disturbances, but even patients who don't complain about night sweats can still have sleep disturbances. So in the SWAN study, they found that 38% of women, even in from 45 to 55, had difficulty sleeping. And there's multiple factors for that. So sleeping difficulties tend to happen as we age, but also if we have night sweats, we have stress, we have psychological factors. If we are drinking large amounts of alcohol, can all have effect. Similarly, if you have other diseases like obstructive sleep apnea, thyroid disease, diabetes, and anxiety. So when we talk about mood, again, I'm not going to belabor the point, but when we talk about mood disorders, very prominent in the menopause transition. 45 to 70% of women can have depressive symptoms, even in the perimenopausal period, and we can see up to 25 to 30% in the premenopausal period. So there was a study done, the Harvard Mood and Cycle Study, that found that twofold increased risk for depressive symptoms and clinical depression are seen in perimenopausal women when we compared them to premenopause. So it starts early, even before that final period. Cognitive changes. So Dr. Black kind of mentioned this. So that brain fog, not feeling as sharp, that can happen in up to 44 to 62% of women who are transitioning through menopause will report cognitive decline. And in particular, they complain about more kind of forgetfulness, difficulty recalling words, ability to retrieve information, and even concentration. Luckily, the ability for new learning is not as effective as the other cognitive functions. And luckily, this tends to be a transient type of phase, and it tends to resolve after the menopausal transition. We talk about muscle aches and pains, so it's called the arthritis of menopause. So more than 50% of women report these kind of aches and pains, arthralgias. It may be transient and self-limiting. If it is something that persists long after the transition, we have to look at other chronic medical illnesses that may be present. So that can be autoimmune arthritis, tendinitis, thyroid disease, and vitamin D deficiency. So weight changes is something that can happen as we age. And as we know, weight is, or obesity and overweight status is very chronic in Western population and worldwide. So when we look at weight and menopausal women, 43% of menopausal women are obese. So they are going into the transition overweight or obese, and they tend to have a harder transition because of this, more vasomotor symptoms, more mood disturbances. So we know that weight gain at midlife is related mostly to aging and lifestyle, not directly related to menopause or hormone replacement therapy. However, we know that menopause does create other factors that can lead to affects kind of weight. So if you're not sleeping well, obviously you're going to have more elevated cortisol. You're going to have lower leptin, which helps to control your satiety, how much you feed. You can have more prediabetes, impaired fasting glucose. If you're not sleeping, you feel tired. So you're not going to want to exercise. So if you don't exercise, obviously you're going to have some weight gain. We know through the transition, again, you have loss of lean muscle mass and increase in central adiposity. And the lean mass is really what's important for my colleague's going to talk about sexual dysfunction, but again, this is a common problem, and it relates to a lot of emotional issues, relationship issues, and social functioning problems. So when we talk about menopause management, there's kind of cornerstones to care. So there's going to be lifestyle management. So what I alluded to is that, being overweight or obese going into menopause, you can have a harder transition. So you want to, get lean, get active. There is menopausal hormonal therapy, which I'm going to talk about. We'll talk about some of the non-hormonal treatment. I'm not going to talk a lot about vaginal dryness because my colleague will talk about it. And we'll talk about some other complementary therapies that are on market. So when we talk about lifestyle, so simple things like avoiding spicy food, reducing alcohol, caffeine intake can help to reduce vasomotor symptoms. It's always better not to smoke, but smoking can make vasomotor symptoms worse and obviously put you at risk for cardiovascular disease. Eating a balanced diet, nutritious diet, maybe including foods that have some phytoestrins like soy, making sure you're exercising regularly. Try to get enough sleep. And if you're still having difficulties sleeping, discuss that with your doctor. You may benefit from supplements, sleep aids, and the such. And then keeping cool strategies, dressing in layers, stripping off, the layers at night to help keep cool, using fans. So those would be modification behaviors. So when we look at who should get hormonal therapy, FDA-approved indications would be vasomotor symptoms, so having hot flashes, night sweats. We use it for the prevention of bone loss or to help prevent osteoporosis. It's not a FDA-approved modality for osteoporosis management. And we always want to treat women who have premature menopause. So they either have autoimmune condition that's led to premature menopause or they've had surgical menopause. We would want to treat them with hormonal therapy to reduce their risk of cardiovascular risk. And in women who have genital or urinary symptoms, you would also consider hormone therapy. So when we look at which meds perform better for hot flashes and night sweats, hormonal therapy is always going to perform better. So estrogen performs the best in relieving these symptoms. However, there are non-hormonal therapies that can be used if there's contraindications to non-hormonal therapy. So these tend to be SSRIs or SNRIs. So these are antidepressive, anti-anxiolytics, which can help, or you can use things like gabapentin. If you look at the chart, a lot of our common over-the-counter supplements, black cohosh, ginseng, and these type of things, some of the studies have not really shown proven benefit. It's more anecdotal, where you'll have a cohort of patients saying they're proven. It's been really no randomized controlled trials that have shown benefit. And some of these supplements, you really don't perform much better than placebo. So what are the contraindications to hormonal therapy? So one will be unexplained vaginal bleeding. So as Dr. Bo said, is that you really shouldn't be bleeding in the postmenopausal period. If that's happening, that needs to be evaluated. So that would be a contraindication to hormonal therapy. Patients who have estrogen-sensitive cancers, breast, ovarian, or endometrial, triple-negative breast cancer, especially in that first 5 years, it would be contraindicated. Patients who have active coronary disease, stroke, or heart attacks, that would be a contraindication. History of clotting, severe active liver disease, and then also patients who have peanut allergy, because some of the progestins that we use have peanut oil base, so that would be a contraindication to using those progesterones. You want to have caution in patients who have migraine with aura. It's not an absolute contraindication because hormonal therapy, the hormone dosing is much lower than you would use in the premenopausal period. So a lot lower than OCP. So it's a relative contraindication. Patients who have gallbladder disease, high triglycerides, a high risk of breast cancer, so maybe familial risk, if it's even a few family members removed, or in women who are over 65, you want to be consider caution in starting hormonal therapy in those patients. If they're already on it, you can continue if still symptomatic, but you don't want to start in someone who's kind of been out of menopause for more than 10 years. So when we think about hormonal therapy, there's a whole slew, but classic, we think about estrogen. So if you don't have a womb, it can be estrogen therapy alone. If you have a womb, it'll be estrogen and progesterone therapy. For other things, you can use SERMs and tissue-selective estrogen complexes. But classically, we think of estrogen or estrogen and progesterone combination. So what are the prescribing principles for hormonal therapy is first, it's individualization. It's not a blanket, everyone's treated the same. You want to identify the symptoms, which symptoms are causing the most distress. You also want to know what risk factors or contraindications do they have to doing hormonal therapy. The timing matters. Again, like I said, you want to start it within 10 years of the onset of the last menstrual period or prior to the age of 60. Because can be done continuous, where you're getting something daily through maybe a combination patch or through tablets added on to estrogen, or it can be cyclical, where it's 10 to 14 days of the cycle. It's important to let patients know so they're aware is that bleeding is very common in the first 4 to 6 months of starting HRT. It usually resolves on its own. If it is something that is persisting past that, then they would need to be evaluated by gynae with an ultrasound and a possible endometrial biopsy. When we're talking about hormonal therapy, we really want to just abate the symptoms, right? So it's to help you through this transition period. It's not to make you feel like you're 20 again. It's to help with the quality of life, the distressing symptoms, and the resolution of that. So we always want to start the lowest dose of estrogen. And if the lowest effective dose helps to abate the symptoms, that's what we're going to do. You want to set expectations, right? So you want to let patients know that it may take up to 10 to 12 weeks for you to feel some improvement. And again, you may need combination management, where it's not just HRT. You may need a little bit of vaginal estrogen. You may need, if weight is still an issue, some weight loss medications to help with the weight. So it may be a multifactorial approach. A lot of the HRTs will come in orals, creams, gels, or transdermal patches. The guidance is that, transdermal patches, in particular, the estrogen transdermal patches are best. There's lower risk of clots because they avoid the liver, the first pass effect from the liver. It gives a continuous stable dosing of estrogen, and then progesterone can be added on for either the 10 to 14 days or daily dosing. So how do we monitor hormonal therapy? Once the patients are stable, they can be evaluated annually, but when they're first starting the dose, or if they're having some adverse effects where, they're bleeding, or they're still having some persistent of symptoms, you want to see them more frequently, maybe every 3 to 4 months. They should have patients should always have an annual mammogram as part of their cancer screening. Again, if abnormal uterine bleeding persists, patients should be referred to gynae to get involved for further evaluation. In terms of doing blood testing, that really is not standard of care. So as endocrinologists, we tend to do the hormonal testing only if patients are on therapy and they're still having persistent symptoms, to try to evaluate, is it an absorptive issue? Are they not absorbing from the patches? Are not they absorbing appropriately from the oral? So try to troubleshoot. So the clinical goal of treating patients is, again, using the appropriate dose, discussing the route of administration. We always talk about duration of how long we're going to do it. There's no absolute cutoff. Again, that's individualized. We tend to discuss tapering by the age 60, but again, some patients are having persistent symptoms, so they may be on therapy past that. So again, this is what I highlighted, is that there's no hard cutoff on when you have to stop hormonal therapy. But classically, somewhere between 60 to 65, the discussion should be had. We should always reevaluate patients to see if we're tapering, are symptoms reoccurring, are these symptoms distressing? So these are patients who may need more prolonged therapy. We always want to use the lowest dose, and we talk about route, and it tends to be transdermal to have the least amount of side effects. When we talk about vaginal estrogen, there is no cutoff for that. So low dose vaginal estrogen can be used at any age for an extended duration if needed, because like I said, these symptoms, vaginal symptoms, tend to persist indefinitely, and they can worsen over time. So when we talk about non-hormonal therapies for hot flashes, we talked about weight loss, but there are mind and body therapies such as hypnosis and cognitive behavioral therapy, what I'll talk about a little bit. There's procedure interventions, which my colleague will discuss, but there are pharmacological non-hormonal treatments. So if you have a contraindication to estrogen therapy, or you just are not keen on going on hormonal therapy, these non-hormonal pharmacological treatments are an option. So that would be like paroxetine, citalopram, venlafaxine or Effexor, and desvenlafaxine, gabapentin, and oxybutynin. And if you also are having anxiety or depression along with the hot flashes, some of these agents are good options because they'll have dual effect. So we talked about dietary supplements. So as women, we are bombarded about supplements that help with hormones. So the issue with dietary supplements are they're not FDA regulated. So there's a wide range of vitamins, minerals, herbs that are out there that claim to have benefit and to reduce symptoms, but they're not regulated by the FDA. Any manufacturer can make claims saying that their products can work, and they're not. There's no prohibition to do that. There's no anyone stopping them from saying that. So, however, what they can't do is claim that there is disease benefit. So, we have to take this with a grain of salt. In terms of, there are supplements on the market that have some limited data. Again, not any big randomized control trials, but kind of smaller studies that show some mild benefit. Those are going to be like the soy extracts, the pollen extracts, the ammonium succinate, lactobacilli, or rhubarb. Unfortunately, a lot of the popular supplements that patients take, there's actually no data. The data is actually, there's studies been done, but they show that they don't perform any better than placebo, so any better than a sugar pill. So that would be like wild yam, evening primrose, maca, vitamin E, or milk thistle. So when we talk about mind body therapies for vasomotor symptoms, this is another consideration for kind of lifestyle management. So when we talk about cognitive behavioral therapy, this is actually therapy. So it's actually 4 to 6 sessions. There's education and physiology of vasomotor symptoms are discussed. You're taught how to incorporate your thoughts and emotions and perception of these changes, and then you're trained in terms of strategies to how to maneuver during a vasomotor response. So during a hot flush, during these night flushes, how to manage it better. And this can be individual or group led. It can be led by clinical psychologists, and it has been proven to have some benefit. So there's been studies that show that it's benefit in reducing vasomotor symptoms. Another mind-body therapy would be like clinical hypnosis. Again, there are studies that show this has proven benefit in comparison to controls, where it can help improve vasomotor symptoms. I'm going to talk briefly about testosterone. I think there will be some overlap with Dr. Phillips, but in my practice, this question comes up a lot. Testosterone therapy. So testosterone therapy, Endocrine Society, Menopause Society, there is some utilization of it, in particular for hyposexual disorders of menopause. So low libido, low libido, other types of sexual dysfunction, testosterone can be considered to help improve arousal or desire. So we know as women age, androgen levels start to decline. And, when you get into the menopause, there's not a big decline, but it declines as we age. And we know that androgens like testosterone influence female sexual function. It plays a big role in arousal. However, before you consider testosterone therapy, once you want to make sure that there's no other medical issues going on that's going to cause that's causing sexual dysfunction. So rule that out. Also, testosterone therapy is usually started after estrogen and progesterone has been replaced. So once that's been replaced and patients are still complaining about libido, hyposexual desires or disorders, we can then consider testosterone as an add-on to that therapy. So when we think about testosterone, it's going to be 1/10 of the dose that the women will receive in comparison to the male dose. So 1/10 of the male dose. You're going to do it as a trial period over 6 months, and it can be used up to 2 years, and it may improve sexual function. However, if patients don't feel any benefit from adding it in after 6 months, then it should be discontinued. The meta-analysis showed there's no severe side effects in adding physiological doses of testosterone. So what you're trying to do is just replace the testosterone back to the premenopausal range. We're not trying to boost you into the male range. Obviously, that would cause facial hair growth and balding. So it's really just trying to get you back to that premenopausal range. Unfortunately, there is no FDA-approved formulations for postmenopausal women to use testosterone in the US. There are formulations available in Australia. So again, it would just be using 1/10 of the male dose to achieve that benefit. Again, I'm going to skip over vaginal estrogen, as my colleague is going to discuss that, and she's also going to discuss genitourinary symptoms of menopause. So I wanted to bring up a few questions that I tend to get a lot from my patients. So the first thing is, when we talk about you may benefit from HRT, they're always concerned about, breast cancer risk. So the breast cancer risk in patients who do not have a prior risk of cancer and who are starting hormonal therapy is very low. So there's less than 1 cases per 1,000 women per year who are using hormonal therapy, or 3 additional cases per 1,000 women when they've used it for 5 years. And this is when you're using kind of standard therapy. The risk is similar to modifiable risk. So the risk of developing breast cancer in patients who have hormonal therapy is basically the same as women who drink 2 alcohol beverages today. That increases your risk of breast cancer, or being obese, or having low physical activity. So there is not an increased risk in comparison to other women who are not on hormonal therapy. So Dr. Rand talked about cardiovascular risk, but this is a big question that most patients come and ask me. Okay, so what about my heart? So I talked to my friend. My friend said, if I start hormonal therapy, I'll get a heart attack or stroke. Is that true? No, it's not true. So again, hormonal therapy should be started in the right person, meaning it should be started just after the transition if you're symptomatic. So within 10 years of menopause and started in the age less than 60. Observational data and meta-analysis show that if we're starting in this type of patient, there's actually going to be a reduced risk of cardiovascular disease and events. We are only seeing more events, and especially in the WHI study, is that in patients who were started at after the age of 60, and they were actually started on big doses of estrogen who had cardiac events. Those who have, so always want to talk about personal or family history of cardiovascular disease, stroke, or blood clots or breast cancer. We always want to discuss that before we consider hormonal therapy. Or is HRT going to help me to lose weight? I get that a lot, that question. Or is it going to help me, or is it going to cause me to gain weight like I used to be on OCPs when I was, 30 and I gained weight? Is HRT going to do that? No, not really. So HRT may help to attenuate that composition of the deposition of the adipose in the stomach. So as I said, when you go through menopause, you lose skeletal muscle and you can gain some adipose fat in the abdomen. It can help to modulate that. But in terms of weight loss in general, the effect is really small. So HRT can have a favorable effect on the waistline. It can help reduce diabetes, but it's not a weight loss drug. So if you are obese and you need significant, or overweight and need significant weight loss, there's other modalities and treatments that we can discuss. Another question that I get commonly is hormonal therapy going to help my bones? My mom has osteoporosis, so am I going to have dual benefit? So yeah, so hormonal a treatment for osteoporosis. So if you have osteoporosis, we need to consider other treatment options. And it can help, again, when started in the right person, started early in the transition, it can prevent bone loss. And it's important if you're going to consider transitioning off of therapy that you can lose bone. Again, estrogen is being pulled off. However, no studies show that there was any fractures after discontinuing therapy. Another big question I get is, will HRT prevent me from getting dementia? I'm worried about my memory. I sometimes forget where I put my keys or where I put my purse. So HRT is not recommended as a treatment to prevent dementia or cognitive decline. Okay. However, if it's started late in patients, so if you're starting it after the age of 65, it can actually increase the risk of dementia. In the WHI memory study, 23 cases in 10,000 person years in women who were on equine estrogen developed dementia. Estrogen may have cognitive benefits, in particular, initially after a surgical menopause, so after someone has had a hysterectomy and removed the ovaries, estrogen can help with cognition. So that brain fog and that word finding difficulty, it can help. But in patients who go through natural menopause, starting estrogen therapy tends to have a neutral effect on cognitive function. What about mood? Would starting a HRT help my mood? Because I've been moody. My husband says I'm moody. So there is some evidence. Estrogen has an antidepressant effect. And it can have a similar effect as that of starting an antidepressant in that early transition. So in perimenopausal symptoms who have hot flashes or not, starting estrogen or replacement can help. There's evidence that estrogen enhances mood and improves well-being. Even in non-depressed perimenopausal women, there may be a positive effect. However, estrogen is ineffective as a treatment for depression once you get into postmenopause. If you're having depressive symptoms, you need to speak with a psychiatrist, psychologist to talk about therapy. So bottom line, hormonal therapy may help with mood in the menopausal transition, but not in later transition. You got to watch out for rebound mood symptoms when you stop hormonal therapy because those mood swings may reoccur. So compound hormonal therapy is a question I get all the time. I read on Google that compounded hormonal therapy is better, it's safer. It's no such thing. So when people are marketing compounded hormonal therapy, or they're saying compounded is bioidentical, it's more similar to us. All of the FDA-approved hormonal replacement therapies are bioidenticals. They're very similar to what the body is making. So it's not that just compounded has that benefit. The danger with compound hormone replacement therapy is that there's no regulation. So these are being mixed in pharmacies, but there's no oversight. There's no regulation. So there could be overdosing, there could be underdosing, there could be impurities. We don't know if they're using sterile techniques. So all of the governing bodies recommend against compounded hormonal therapy. But again, it's a shared decision making. So you always want to discuss the patient. They're the most important part of the relationship. But you kind of discourage compounded. There's a few rare situations in which compounded bioidentical can be considered. If patients are having allergies to ingredients in government-approved formulations, dosages are not available in the government products. So it's very few situations when you want to consider that. So in summary, in menopause, there's a multitude of symptoms that may occur with varying degrees of bother. 80% of women will have symptoms. Lifestyle management, weight loss, cognitive behavioral therapy, and even acupuncture can help. HRT is the most effective treatment for vasomotor symptoms and genitourinary symptoms. It can prevent bone loss and prevent fractures. You want to start in women who are less than 60 or within 10 years of menopause, who don't have any contraindications. Treatment should be individualized. You want to use the smallest dose to create the biggest effect. Don't use compounded hormonal replacement therapy. It's not safe. Over-the-counter supplements are complicated. Some can work, most don't. And then if you're having genitourinary symptoms, vaginal estrogen is an option. And then for women who have sexual dysfunction, testosterone therapy as an add-on to estrogen and progesterone is an option. All right, thank you.
Thank you very much, Dr. Ariane Davis-Simmons. That was a huge mouthful. And thank you for highlighting all the treatment options available to us. So there's a lot to think about for our participants and listeners. And now we move on to Dr. Dorita Francis Phillips. So she's an obstetrician gynecologist, and she will be discussing the gynecological symptoms and treatment and sexual health issues. Welcome, Dr. Francis.
Good evening. Okay, so this evening we're going to discuss continuation with menopause. We've learned so much this evening about menopause, so my presentation has practically been done for me by my smart colleagues, but just to recap a little bit of what was stated earlier, and I promise I won't keep you very long. So menopause, I like to think about it as a spectrum. So it starts basically perimenopause, which is also referred as the menopause transition, and then ending, of course, menopause, and then the postmenopausal period. So I like to tell patients you don't just wake up one day and you're menopausal. So for most women, this menopausal period or perimenopausal period typically starts in the 40s or early 40s, and it may actually last for several years prior to menopause, and is actually noted by fluctuations in ovarian function and the hormone cells. The concentration basically starts to decline and fluctuate during this time. So some women may actually complain of skip periods, or the periods are basically, as I like to describe it, as becoming a little bit more erratic. So instead of having a simple 28-day cycle when you have a perfect menstrual cycle, or a 30-day, your cycles may actually start to extend to about 40 to 60 days, or some women may actually even have more frequent cycles. So what typically happens in menopause is that the hormonal levels themselves start to decline. So estrogen decreases as the ovaries pretty much run out now of eggs. So ovulation may still occur, and this is why sometimes we have some females that may conceive during this time, as strange as that may sound, but it happens. So you may ovulate. Your ovulations just may become very irregular. Now, if we remember, basically when we ovulate and the egg is actually released, what is left behind is what we call the corpus luteal cyst. And that actually produces the progesterone that is found in the body. So I like to think of the menstrual cycle itself as basically a very complex entity involving controlled from higher centers in the brain, the ovaries, and also the uterus. So things are happening in all areas as we speak of the typical menstrual cycle. So while the ovulation is actually occurring and the egg is being released, likewise, hormones are acting on the lining of the uterus to actually prepare for implantation, expecting fertilization to occur. So in typical scenario, the lining of the uterus becomes thick and it basically anticipates pregnancy. And of course, if there's no fertilization, then the corpus luteum basically disintegrates and then we have a menstrual cycle. Now that whole process there basically becomes very erratic with persons in the perimenopausal period. And so they may actually have cycles that are very heavy or very light, and then a mixture of both heavy and light cycles. When we look at the picture that depicts postmenopause, so we've basically depleted this ovulation or estrogen supplies, and so our level of hormones basically decline. So as has been stated before, what is menopause? So menopause basically is a time in a woman's life when periods actually stop. And so some persons look forward to this, but looking forward to the cessation of menstruation, but not typically looking forward to some of the symptoms that occurs with it. And so the diagnosis is actually one that is clinical and it is made retrospectively, meaning that we can only determine that you are actually menopausal if you have missed your menstruation for 12 consecutive months. So unlike in the perimenopausal, where you may actually miss a cycle for a few months and then have a bleed, whether it's normal or irregular, in your menopausal state, there's no periods for 12 months. So that also means there's no more childbearing. And the average age worldwide is about 51 years. So, okay, why do we have to go through menopause? Well, it's actually a natural process of aging. So if we live long enough, we will encounter menopause. So the ovaries basically are producing declining amount of hormones, our estrogen and progesterone levels. And we no longer have basically eggs being produced. So we've talked a lot about estrogen this evening, and this picture basically just depicts how important estrogen is in all aspects of our bodies, from the brain right down to the heart, which we mentioned earlier, the liver, and of course the uterus, which we hear a lot about, the vagina, and then your bone health all respond to what estrogen does. So estrogen in itself, as my colleague mentioned, we are partners with estrogen for so long, and then suddenly the body becomes depleted. So for some women, menopause is just very simple and very easy. I come from a family with a lot of females, and I don't think I've ever heard a complaint about menopause. And then I started to transition and get old myself, and I'm like, what? No one didn't explain some of these things to us. So some people will just go through menopause without any symptom and just one day recognize that, hey, I have not had a menstrual cycle in so long. And so those persons are very fortunate. The more common symptoms or complaints that women will have with menopause, or I should say the most common, and this is what I will be referring to this evening, is basically the vasomotor symptoms. And these symptoms refer to as the hot flashes, or some say hot flushes, or the vaginal symptoms. And we'll get right into these things here. So the picture on this page, basically highlighted in orange, shows us the most common symptoms, which is the hot flashes. So basically what happens as we go through menopause with the loss of estrogen, the center in the brain that actually controls thermoregulation or heat regulation is altered. And so it's narrowed. So very slight changes in temperature is basically we're not able to readjust, for want of a better terminology. And so it's a sudden change of a flushing sensation. Women complain of being overly heated. It lasts for maybe 1 to 2 minutes, and is usually felt on the upper aspect of the body, involving the face, the neck, the chin, that area. Some women may actually also have those same symptoms at night, and we refer to those as night sweats. So with night sweats, it can become bothersome because you basically break out in a cold sweat, and then that makes you overheat. Then you become very cold. So it's like a cycle of hot and cold. So many women will actually present complaining of being cold, then hot, hot, then cold. So the blanket goes on and then it goes off. Irregular periods, loss of libido, vaginal dryness. These are some of the common ones. And of course, the mood swings. So I like this diagram here. It basically tells us some of the same things, but it actually tells us the symptoms as it relates to different aspects of our body. So with the central nervous system, we have some of the vasomotor symptoms that we spoke about earlier. We have the sleep disturbances, and of course, the cognitive changes. So the memory lapses, the depression, the anxiety. We spoke about things that happen with the metabolic aspects of menopause, particularly with the weight gain. And so most women will complain about that increase in visceral fat. So no matter what or how much exercise you're doing, the weight seems to just center around the waistline. And most women don't like that. All right, the urogenital symptoms, these are so important, and it's a nuisance, becomes a problem. And as it relates to the menopause, it's associated with vaginal dryness, sometimes itching in the vagina. Some women actually may have an itch or a burning sensation, or it also affects the urogenital system in terms of how often you have to get up to pass urine, you have peeing frequently, you cannot get to the bathroom in time, sometimes even incontinence. And some women, believe it or not, actually, their symptoms of menopause may just simply be recurrent urinary tract infections. So the sexual aspect of menopause, it affects everything. So your intimacy becomes a problem because your sex drive, one, is altered. You're no longer interested in intimate relationships, or sex just simply becomes very painful. And so naturally, you're not inclined. And so we're going to get into a little bit about that earlier. And also with the loss of estrogen, my colleague spoke about the risk of bone loss and therefore osteoporosis. So this picture here just basically repeats some of the symptoms relating to the vaginal findings or complaints that most women will have. And as a gynecologist, this picture is important because it actually tells us what a lot of females will come in complaining about. And I'll also like to say, sometimes it takes us taking a little bit more time with our patients to dig things out because they may be a bit sensitive about this issue and they may be less willing to discuss some of these complaints. So we spoke about the vasomotor, and I also want to speak a little bit more about the genitourinary symptoms and why they occur. So it is a chronic progressive condition, which basically causes alterations in both physiological and the anatomical aspect of the female genital tract. And so what does that mean? So physiological, it affects how things operate. Anatomical, it actually causes changes to the structure of the area down there, structure of the vagina. We will see a bit more about that. So of course, it all relates to this decline in the hormone levels. It affects about 10 to 50% of women in the menopause and postmenopausal aspect of life. Unlike the vasomotor symptoms, sometimes the vasomotor symptoms will improve as you progress through menopause. They actually improve. So you would realize that the night sweats or the hot flashes actually stop or get better. But with the genital urinary symptoms, they do not go away. In fact, they may worsen, particularly if they're not treated. And so that is something I'd like to speak about because it's going to have great impact on a woman's relationships, her body image, and of course, sexual health. So someone mentioned earlier about doing a diagnosis for menopause. So how do you know if you're actually in menopause? Well, it's usually pretty clinical. So you've gone through that time where you have those consecutive period loss. We don't usually do blood tests. A lot of times patients will come in and they'll say, Doc, can you just do a blood test to confirm that I am in menopause? It's not something that we like to do, but there are times when it may be useful. And this may be useful for patients who have who are basically encountering menopause symptoms early. So if you have premature ovarian failure, these are some of the patients that you may want to look at, or even someone basically who is still trying to deal with fertility aspects of life, and menopause is starting a little early in the 40s. And so that will be depicted by using the FSH levels, which are elevated along with a decline in estradiol. There are some times that we may incorporate other hormonal levels because this can rule out other medical problems that may mimic the symptoms of menopause, for instance, thyroid disease. So now that we understand that we are there, we are in menopause, Doc, what do I do? How do I live? Am I going to just shrivel up and die? Well, no, of course not. There are things that we can do. So Dr. Ariane Simmons would have gone over some of these things that we can do to basically help. And they may seem simple, but some things that we can incorporate or change now in our lifestyle will actually make us feel much better. And so one of those things that we find women doing a lot of is drinking a lot of coffee, having a lot of caffeine. That's going to heat you up, and that's going to basically worsen your menopause symptoms. Likewise, spicy foods and alcohol. These are things that we can actually change. So these are some of the simple habits. I'm just going to run through these because we spoke in detail about them earlier. So a lot of lifestyle changes. So I usually encourage my patients to begin, if you were not exercising, if you basically became menopausal in an obese state, you will have some difficulties. So you have to make some lifestyle changes. And there's no basically soft way of saying that. So I do encourage exercise. I do encourage changing a diet to a more balanced or healthy diet. And I do involve exercise with some weight training because the resistance is good for us at this age. So of course, hormonal replacement therapy. This is what everyone wants to know about. Dr. Ariane Simmons has talked so much about it. I'm just going to basically highlight just a few things here. So of course, it relieves a lot of symptoms of menopause, and it seeks basically to give exogenous estrogen to replace those that we lost having gone through menopause. It is, however, very effective. So despite the noise in the market, hormone replacement therapy is still highly effective for treating particularly symptoms of vasomotor symptoms and our symptoms that relates to the genital tract. So it is associated with about a 75% reduction in the frequency and also to a certain extent the severity of your hot flashes. So for patients so the mainstay of hormonal replacement therapy involves estrogen. So estrogen is the common hormone that is given in women who have already had a hysterectomy. Then estrogen alone is fine. For those who basically still have a uterus, we want to give progesterone either cyclically or in combination with the estrogen, or continuously or cyclically, with estrogen, as we cannot afford to give women estrogen alone because it's unopposed and it's going to have tremendous effect on the lining of the uterus. So hormone replacement therapy, the sooner after menopause is better. Within the first 10 years, ideally for women less than 60 years and of age. And if we can, the lowest possible time possible and the lowest possible dose. In terms of this picture, just basically talks about different hormonal replacement therapy options or non-hormonal therapy options. So I like to look at treatment of menopause in terms of your non-pharmacological, Your pharmacological would include hormonal or non-hormonal. So when we talk about treatment of hormone replacement therapy utilizing estrogens, we can utilize estrogens either at the standard dose, but the standard dose basically is associated with more adverse effects. And so it's always best to use either the low dose regimens or the ultra low dose regimens. And so we start at the lowest dose for the shortest possible time period, if possible. So testosterone and progesterone are not FDA approved for treatment of menopause, but they have had some assistance in the symptoms of menopause. Tibolone is one of those medications that actually has been effective in treating menopausal symptoms, and it may actually have beneficial effects on areas of the bone and prevention of osteoporosis. The compound bioidenticals, of course, these are compounds that are pretty much almost biologically, structurally, and physically similar to our hormones. But as we mentioned earlier, they are not FDA approved just because sometimes we cannot regulate. We're not certain of all the strengths of it. We're not certain if they're marketed with the same potency. And so we do use them or advise them with cautions. So for some patients who are not suitable to use hormonal replacement therapy in terms of the estrogens or progesterone, depending on the risk, as Dr. David Simmons mentioned earlier, then the SSRIs or the SSNRIs, which are commonly some of your antidepressants, are also beneficial. Gabapentin has also been proven to be effective, and this medication actually has been cited to reduce some hormone the vasomotor symptoms by about 54%, and also may decrease the severity of those symptoms by about 52%. So in terms of, we mentioned that the vaginal symptoms associated with menopause will require at some point in time treatment, as these symptoms tend not to resolve. The good thing about hormone replacement therapy is that it's afforded to us in many different regimens. So it can be orally, it can be done in patches, in gels, or in sprays. And so typically for your vaginal symptoms, we like to use a lot of local vaginal therapy. That's also very effective. And then there are some newer agents online now for patients who are not able to tolerate the estrogens. And this is osphene, which is actually a medication that's now highly effective and FDA approved for vaginal symptoms. And of course, if you're not using hormonal or pharmacological, then vaginal lubricants and moisturizers can be considered as more or less some of the first lines. So the benefits we've mentioned, of course, is very effective. It helps you to have a better quality of life, and it reduces the risk of osteoporosis. It may be associated with breast cancer and some of the things that have been mentioned earlier. So I just want to quickly just get into some of the aspects of sexual health. So sexual health is a state of physical, emotional, mental, and social well-being that is related to sexuality. So a woman's intimacy. The female sexuality is definitely an important aspect of women's health and something that we cannot basically overlook. As women are living longer lives, this becomes a problem, particularly in our aging females. And as we know, our sexual function declines with advancing age, and it may be multifactorial. So the menopause definitely has an effect on sexual health, and it's all related back to the declining levels of estrogen, and we call vaginal atrophy, where the vagina becomes drier, thinner, and it makes sex and intercourse less enjoyable. But there are other factors that actually may lead to this, and that includes fatigue, because we notice that menopause also is affected, or your menopause affects your quality of sleep. And so if you're sleepy, if you're sleep deprived, you're going to be moody. If you're moody, of course, you're not going to be very much in a person to be engaged in sexual intimacy. So the sexual function, of course, worsens with menopause, and it tends to affect about as high as 88% of women. So that's quite common. Most times you may not hear about this because this is something that's sacred, and most women will not just easily engage in this conversation unless they are very comfortable. And some of the factors that affect the overall sex life will be the desire. So low desire associated with menopause is as high as 69%. And this is the lack of sexual desire, a lack of interest in sex overall. And of course, low arousal. So it's inability to become physically aroused or excited. So if you're not able to have any excitement, you're very uncomfortable, the sex is painful, it's definitely not going to be something that you enjoy. It's not going to be something that's going to be on the forefront of your mind. You will really be trying to avoid it rather than engaging in it. So we have focused so much on estrogens, but newer studies have brought androgens back onto the scene. And because they realize that not only estrogen controls the woman's sexuality, but androgens themselves may play equally or an even more important role in the performance of your sexual intimacy. And so we also know that these same sex hormones, which were basically founded in young girls as they go through puberty, it's important for the development of our sexual characteristics. And it's also very important to maintain a healthy genital tract. And so once these hormones become now depleted, we sort of reverse. We go back to what we look like prior to puberty. So this diagram basically shows you, so we're talking about some of the things that it causes as it relates to the genitourinary tract. And so basically there's a loss in the blood flow that decreases with menopause. There's thinness of the vaginal lining becomes thin and dry. It loses the elasticity, and the vaginal tract itself may actually shrink in. And so sex in itself is very unbearable. So the effects of menopause relates to the anatomical, and some of those painful syndromes are related to sex. So what do we do about it? So basically, our first line approach is not always pharmacological therapy, but it actually may just involve sexual education. Some persons may just need to understand what their body is actually going through, the changes that are being made, and certain things that we can implement to make sex a little bit more enjoyable. It's always best to have a partner present, because a lot of times our males are not quite aware of the things that actually occurs in a woman's body and the changes that they go through. And so I think by educating both partners, it helps to improve. So of course, we would have mentioned earlier that some of the more simple things we can do as the symptoms become more progressive would be your lubricants and your moisturizer. Pelvic floor therapy is vital. Sex therapy and cognitive behavioral therapy also becomes involved. For patients who have moderate to severe, we may rely on local estrogens, and these actually can be done by inserting vaginal creams. And for patients who have severe pain along with menopause, then we can use some of our newer agents like the osphine. So in summary, hormone replacement therapy, whether it's estrogen or estrogen in combination with progesterone, is the most effective and remains the most effective therapy for vasomotor symptoms. We start at the lowest effective dose for the shortest period of time. We make sure that we evaluate the risk of cardiovascular disease and thromboembolic events and/or breast cancer. Estrogen therapy is most effective for women with genitourinary symptoms. And as stated earlier, herbal supplements and phytoestrogens are not as effective as our hormone replacement therapy. And I thank you.
Thank you very much, Dr. Dorita Francis Phillips. And thank you for highlighting the issues related to genitourinary syndrome and vaginal atrophy. You know, working as an internist in hospital, I could attest to the increase in admissions in hospital for frequent urinary tract infections in women over the age of 65. And a lot of it is related to the genitourinary syndrome of menopause. And so we move on to our next topic, how menopause affects you psychologically. And a lot of our speakers have alluded to it, but Dr. Stephanie Hutchison is going to come, psychologist, and enlighten us on this topic. Welcome.
Thank you. So where the fans at? Okay. My inspiration for the title of this session is from a popular line dance right now called Boots on the Ground. And where them fans at is a call that runs throughout the song. So when I thought about the hot flashes associated with menopause and the number of people I know who travel with fans, I thought the title was fitting. Two of the most significant biological transitions in women both begin with M, menarche, or menstruation, and menopause. One transition, menstruation, initiates women into childbearing years, and the other, menopause, marks the cessation of menstrual cycles and fertility. These milestones have been viewed with a degree of dread, laden with angst, bad word of mouth press, and negative expectations. Then with menopause, there is silence, a weighty silence. Now menopause seems to be trending, and the silence has erupted in vocal dialogue, podcasts, shows, celebrity testimonials, and a flurry of research. You've heard it over and over tonight. Every woman experiences menopause differently, as varied as those who are on this webinar this evening. And yet there's common ground. You've heard about these symptoms that are commonly reported: low mood, feeling unhappy or depressed. I'm not going to go through all of them. You can see them on the slide: feeling nervous, anxiety, loss of confidence, anger, and irritability. Keep hearing about brain fog, brain fog. Very common symptoms. So these are just a sample of complaints women report. But I want us to get from this webinar tonight that we are being heard, that you're being heard. For example, in 2024, The Lancet, which is a prestigious and well-respected medical journal, published a series of articles on menopause. Researchers in diverse settings and expertise examined studies from over a 30-year period, 1990 to 2023. They sifted through the findings to generate a profile of the typical menopause, and you've heard some of that tonight. But they also included special populations, which were also hinted at tonight. Populations with special circumstances like early menopause and menopause after breast cancer treatment. So a full coverage of these groups is not possible in this webinar in my allotted time. So I'll just share an overview of common psychological symptoms and interventions. Aside from the typical menopause profile already covered, an important theme that emerged from the research was, let's move away from primarily a disease-based perspective and recognize and embrace that menopause is a normal transition as women age. A life transition, albeit with some changes, that can cause disruption and discomfort, but it is a normal life transition. It's not a disease. I think Dr. Black said that earlier. It's not a disease. It's a life transition with these disruptions and discomfort. So rather than the long-standing disease perspective, Hickey and colleagues endorsed an empowerment framework, and I really like that, which includes education, awareness, information, and collaboration with other healthcare providers and women throughout the periods we've been talking about tonight, perimenopause to postmenopause. And this evening, my colleagues have provided the nuts and bolts of what happens physiologically in reproductive health and the menopause transition. My emphasis is on the mental health experience. And I know you've heard a lot about the things that can happen. I think we've just covered the gamut of what can happen, but it's not every woman's experience. And so what I take away from the research I've looked at and my own experience is that even though there are significant changes that persist over a period of time, menopause is not the herald of disaster that we've absorbed from bits of discussion here and there, or we've even conjured up in our mind. I know our conversations on the subject of menopause may be late to the table in comparison with other health issues affecting women, but we're dialoguing now, and the trajectory, the pathway, is more positive than we realize. It's much more positive. As I was reviewing the research and I was thinking about my own experiences and those that I've worked with, it's heartening to review the latest investigations into menopause to complement critical clinical practice, because women's experiences, whether mild, moderate, and severe, and we heard the numbers a little earlier, 60% I think are mild, maybe moderate. Mild is about 20 severe. So we have the bulk of women who have mild to moderate symptoms and complaints during this period. And so the picture is not catastrophic. It's not catastrophic. And to me, this is great news, because wherever there are changes in previous functions, and I hope you got that from tonight, there are ways to help and to support women effectively, to intervene, to educate, and to rebrand how we view menopause and our expectations of what our experiences can be like. And I say are because I'm there. I'm in this stage, even though someone who shall be nameless said they're not. I'm there. We're there. For certain, research and personal accounts attest to women who experience changes in mental health, changes in mood, and for some, a diagnosis of clinical depression. You've heard about cognitive changes that can impact concentration and focus, and then we've also heard about the physical symptoms. But where depression actually is formally diagnosed, once again, there are remedies, there is help, whether it's through talk therapy or counseling or medication or a combination of toolkit of strategies. I want you to come away from this webinar tonight recognizing that whatever the constellation of symptoms you have, that they can be managed. Whereas depression, medication can help. And what this research actually tells us is that most women really don't develop depression during menopause. For someone who has a history, there may be an increased risk. There may be some depressive symptoms, but a full-blown clinical depression is not necessarily most people's experience. Some women report anxiety, but others do not. There's not a great deal of research on the anxiety piece, but most women aren't reporting, in terms of the research done, higher levels of anxiety. And the thing to remember is that even though that depression and anxiety have a great history of treatment strategies that are successful, and these same strategies can be applied to women who present in menopause. So asking questions about mental health is key in healthcare. Let me go back. A common feature, I talked about this already. This has come up often. The women report sleep disturbance. And we don't recognize how important sleep is and how that impacts our well-being. So the sleep disturbance issues, we can see fragmented sleep, difficulty falling asleep or staying asleep, and the interventions used to minimize sleep disturbances, cognitive behavioral therapy for insomnia or CBTI is an evidence-based remedy, and behavioral strategies usually described as sleep hygiene have been utilized. And these are some tips, I'm not going to read them all, from the National Sleep Foundation. I'm spending a little more time on sleep because it's really an important way to help people just to feel better in general, but particularly during this transition period. So going to sleep and waking up at the same time every day, including weekends and holidays when we tend to want to sleep in. You want to regularize your sleep schedule as far as possible. Setting a relaxing bedtime routine. Many of us may have done this with children or younger family members. You had a routine to go to sleep at night. We need to adopt that, to kind of take a page out of that book. Listening to calming music, taking a warm bath, making sure your room is cool to promote sleep, and you can see what the optimal temperature is, 60 to 67 degrees Fahrenheit. It helps to promote sleep. Exercising regularly, but right before bed. You don't want to do that. And trying to limit caffeinated products late in the afternoon. Additionally, It's important to identify sources of stress. So these are some more of the sleep hygiene techniques. Identifying sources of stress, because menopause is often a time of other life transitions, caring for aging parents, launching children into adulthood, empty nesters, late life divorce, called gray divorces, or widowhood and retirement. These changes in roles can compound stress, and you can see some of the ways that we can adopt to manage stress, drawing on our supportive networks and relationships that can be beneficial to help us manage our tasks and responsibilities and our connections. This is not the time to be a lone ranger. Prioritize self-care. See a mental health professional for counseling, because as I like to say, when the road of life takes a turn, a psychologist can help. It doesn't have to be anything big and catastrophic. Just when the road of life changes, like menopause or any other adjustment, a psychologist can help. And so these are some of the other remedies. You've heard about you cannot pour from an empty cup. You've heard about when we travel by plane, the flight attendants tell you put on your mask before you could put on someone else's mask so that you could be of better health. So when the road of life takes a turn, like a menopause transition, a psychologist can help. As I start to wrap up, I have to share that what I appreciate about tonight and this panel of professionals is that it's multidisciplinary. This conversation tonight reflects a team approach that values the total experience of women in menopause, physiologically, in reproductive health, in diet, nutrition, and behavioral health. This team perspective validates all aspects of our lived experiences. And for my part, recognizes that mental health is health too. That's also my mantra. Mental health is health too. And it's an important message to repeat as we're nearing the end of Mental Health Awareness Month. So you will recognize that these group of professionals are not going to send the person to the psychologist because it's all in their head or she's mental or she's crazy, but it's a part of the spectrum of care. Mental health assessment is a part of the spectrum of care provided in the Renew Clinic, and the very name Renew is a departure, I think, from medicalizing menopause. Through education, awareness, and dialogue, we can rebrand menopause and rethink the experience in terms of some of the benefits. Oh, I think I talked about those already. Oh, I think I'm jumping ahead of myself. Yes, I talked about the team approach. Benefits of menopause. Have we seriously given consideration to the benefits of menopause? Think about it. What is gain? What are the benefits? I think you have access in the chat to asking questions, but start populating the chat right now as it comes to your mind about what are the benefits of menopause. Start jumpstarting that thought process. What are some of the benefits of menopause? Because that change in orientation can be very helpful in terms of how you approach and what you expect about menopause. I conclude my segment with this. There was a clothing store in the US called Sims, which went out of business in 2011. I've always remembered their catchphrase. I can even hear the voiceover in my head. An educated consumer is our best customer. If we borrow this catchphrase and maybe tweak it a bit and apply it to menopause, then education, awareness, access to resources, training of healthcare providers in asking the right questions and listening to their patients, the consumer, can shift the landscape and the experience of women in this stage of life. And then in the meantime, let them find that. I'm done.
Thank you very, very much, Dr. Hudson, for that really uplifting talk and reminding us that menopause is not a disease and that there is positivity in it. And yes, my benefit is I am living my best life through menopause. And now we move on to Dr. Janet Martin, and she is our diabetes and wellness educator, who will be talking to us about healthy lifestyle habits and menopause. Welcome.
Welcome. Thank you. Okay, good evening, everyone. If you're still awake and you haven't gone for your dinner as yet, please grab your plate, sit down with me, and have a meal, because that's exactly what we're going to talk about tonight. My colleagues have done an exceptional job on educating us women about menopause. I'm in menopause, believe it or not. And I have learned so much tonight that I thought I knew, but I'm now able to put it in perspective. And so I want to thank you, ladies, and Dr. Rand. So let's get started. I hope you have your meal with you. So today, it's not moving. All right. So I want to start with us thinking about, we've learned so much. I want to start about thinking on self-care. Let's talk about self-care, because that's where menopause begins. It's about us ladies. It is about us when we hit 50 and 60, that is the new 40. And so like my colleague who just finished, she talked about the benefits of menopause. What it does is it engages us and brings on a sense of mindfulness, and we start to care for ourselves. We look at ourselves in the mirror and we see some changes, and we want to do something about those changes. And so some of those changes I like to sit with persons with, and when they come to see me, they talk about nutrition. And tonight we heard all of my colleagues talk about a common thread was lifestyle, nutrition. What are you eating? What are you drinking? What you should eat? What you should not eat? And so I hope you have your meal in front of you, because we're going to have some fun. Fitness. How to move, how important movement is. Movement, believe it or not, is going to help you sleep. Movement is going to give you energy. And how to connect that mind. You know, in menopause, sometimes we get a little fuzzy in the head. If we just get up out of that chair and do some stretches and some movement, that oxygen goes to the brain. So that mind-body connection is extremely important. And I'm going to touch on the spiritual part of menopause, because as women, and men, of course, but as women, we think with our hearts, we feel with our hearts, and that's the spirit within us. And so I thought this was very helpful. If you don't make time for your wellness and yourself and become a little bit, it's about me, then you'll be forced to make time for your illness and spend some of that money that you have saved up. And I don't know why this isn't moving. Can you move it for me, please? Yes. So what I did was, since we're on a roller coaster, I figure, okay, let me make a roller coaster, right? And so this is the lack of estrogen roller coaster here. We get the hot flashes, where them fans at, right? Increase the insulin resistance. And I love that dance, where them fans at. I can do it too. And insulin resistance, that's the stomach. You know, we see this little pug come in. I never had a stomach, and all of a sudden I see this stomach showing up. Well, that's some of the foods that I'm going to talk about tonight that we could help to reduce that insulin resistance and that pudgy stomach. Muscle loss, that also comes from lack of estrogen, lack of estrogen. And I'm using both words interchangeably because we pronounce it differently, some of us. Loss of muscle, increased fat. When we lose muscle, then fat comes creeping in there and say, hello, see me here. All right. And if we don't do anything about it, because we're not sleeping, we're tossing and turning, we're hot, we're cold, we get out of the bed. If we're sharing the bed with our partners, they're so happy when we get out of the bed. Because why? We're disrupting their sleep. Yeah. And so low energy. And then you were supposed to meet me for that walk in the morning and you did not show up. And you did not show up, and you will call me and say, girl, you don't know what happened. Does that conversation sound familiar? And this is where the fact settles. Next slide. So nutritional needs change as we age. Just as in a baby, we feed a baby every hour, then every 2 hours, and then we stretch it out to 3 hours and we give them a little more each time. Well, we're reversing now. We're going back to baby stage in our eating, right? So we need to eat less, and we have to look at because our metabolism slows down. And we heard all of my colleagues talk about what estrogen does, and it increases our energy and metabolism. Well, we don't have any more. At least I don't. So what I do, I get myself moving, okay? Because my metabolism has slowed down and cravings come. You want those chips, you want those cookies. And especially if you're living alone and you're eating alone, you're snacking in the bed and you say, did I eat all of that? Right? We're not even aware that we're performing these activities because we're doing them mindlessly and we're not happy with ourselves. So some of those food choices like the sweet and salty foods, they cause constipation, ladies. Why? Because they don't have any of the things in that big group, the fiber. And so because our eating habits change, yeah, and everything now changes and we're depositing fat, we're becoming insulin resistant, we need to now switch to a more plant-based meal plan. And numerous studies are strongly suggesting that to improve our health, improve insulin resistance, to slow down on weight gain, and to improve our longevity and quality of life, heart health, a Mediterranean diet is it's encouraged, and we have studies that prove that. Now, you heard Dr. Rand talk about your heart health. These same foods, these fruits and vegetables and oils, they're full of fiber, and I'm going to hit on each one of those food groups in the next slide. So I put this, I thought this was so cute. You see, I love chocolate. I'm a chocoholic. You go to Europe, bring me some chocolate. No clothing, just chocolate, all right? And sometimes the other morning they had someone give the nurses some breakfast, and I saw a donut covered with chocolate. Well, I snuck 2. Yes, but then I walked 4 miles. So you see the combination? Yeah, what you eat, you are what you eat if you don't move that body. And so these are some of the foods here on this, eat this column. This is your Mediterranean diet. These 4 food groups are what we call the great carbohydrates. Now, carbohydrates is the body fuel. That is the largest food group. All right? And so there's 3 food groups. There's carbohydrates, proteins, and fats. They're referred to as macronutrients. And these carbohydrates and the eat this list, these ones are the ones that are high in soy. You know, earlier one of my colleagues talked about Japanese and Chinese women. They don't have, they're lower on the percentage range for experiencing these menopausal symptoms because their diets are full of soy. From children, they eat a lot of soy and they eat a lot of plant-based foods. And so, yes, they may experience some menopausal symptoms, but not to the extent of Caucasian and Black women do. And that is why beans and legumes, they're high in fiber and they're also protein. And so protein fills us up longer, and so does fiber. So a carbohydrate is made up of starch, sugar, and fiber. What do you think about this? Don't eat that list. That's just sugar. no starch, and starch, no fiber at all. And that's where the constipation comes from. That's where the change in bowel habits come from. But when we come here to our vegetables and fruit and whole grain foods, then it's going to enhance the fiber that we take in, the vitamins and minerals. And because they're macronutrients, we don't have to supplement with a lot of micronutrients, all right? So the next slide, fruits and vegetables. Why are we eating a lot of fruits and vegetables? Because of all of these protective features, right? They're naturally occurring sugars, ladies. Yeah, so you don't have to go and get the fruit out of the can. Watermelons are in season. Don't eat the whole watermelon though. Just eat slices of it, like 3/4 cup is a serving, right? And they have naturally occurring sugars. They also have a lot of vitamin A's and C's and minerals and fiber and potassium for heart health, okay? So I don't want to stay long. And with the American Diabetes Association, what they recommend is with diabetics or pre-diabetics, instead of drinking the juices, you eat the fruit. Because anything in a bottle or a can has additives. No juice in a can or a bottle that's labeled 100% is 100%. How can it be? Think about those things. Beans, soy. You see why the Japanese women and the Chinese women have less of the symptoms of menopause? Because they're eating soy. And you see the benefits of soy. It keeps our cholesterol down. It's low in fat. It's an excellent source of fiber. It fills you up longer, and it is a protein. So our vegetarian people who don't eat meat or who don't eat poultry or any type of meat, they live off of legumes. And that is where they get their sources of vitamins and minerals from. And that is where they get more of their energy from. All right? And so and these are the serving sizes. It gives you an idea of what a 1/2 cup of edamame looks like, right? And you could throw a little bit of salt on it and flavorful. 1/2 cup of green beans. Yeah? So this gives you an idea of what the serving sizes look like. And we recommend to have 1/2 of your plate with mixed vegetables for the reason that because of all of these beautiful, beautiful benefits, all right? Protein, that's another food group. Protein, ladies, is your good friend as well. Protein will keep you full longer. Where carbohydrates digest in the body within 5 seconds to an hour, proteins digest within 2 to 4 hours, depending on how much you eat and what it is. And so that's why it keeps you full longer. And so when I have patients say to me, can I have a snack? Why do you need a snack? Because it tastes good. It's the mind. It's the mind, right? And so this is what protein does for your body. Protein builds muscle. And that estrogen cycle I told you that we're on, right? We're losing muscle and we're gaining fat. So if you eat protein, look at those guys and women in the gym. They are drinking pre-protein drinks, and then they're drinking after workout drinks. Okay, pre-workout and after workout. But look what protein does for the body. It is a precursor to amino acids, which helps to transport hormones and stuff through the body and to build cells. It increases our muscle mass. It repairs tissues in the body. And so this protein, and it builds bones and nails, and it reduces our risk for heart-related illnesses. It also helps with the exchange of glucose and insulin. So it slows down the amount of glucose when we eat all those carbs. So we do a meal that has some protein, has the low glycemic index carbs, and that's the dark leafy vegetables and other beans and stuff. Then what's going to happen is where the carbs increased that blood sugar, the protein is going to come in and balance that insulin level out, right? And so it will reduce our chances of developing insulin resistance and type 2 diabetes. So how much protein do we need? See, I'm always giving you the sizes, right, on what to put on that plate, right? So how much protein? If you're a woman my size, and I'm not going to tell you what that size is, you can see I'm tall for my yeah. So if you're a woman my size and you're active, you want about 70 to 100 grams of protein per day. So you want to mix that throughout the day. And I say to women, please try not to miss meals. Okay, so if you're intermittent fasting, have your first meal by 11 a.m. Make that your largest meal and then space 4 to 5 hours and have another meal, right? Drink lots and lots of water. All right. But this chart here gives an idea of how much protein we need. And it can range from anywhere from 40 grams per day to 70 to 100 grams, depending on whether you exercise. Fats, 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 fats. These are your better fats, your monounsaturated. They're found in nuts, olive oil, almond butter, avocados. The polyunsaturated fats, you always heard about the omega-6 and omega-3. They're heart health, and they're found in seeds and nuts, and omega-3 flax seeds and salmon. Now you know what our Chinese ladies are doing. Let's do it, ladies. Let's have some fun. Okay, let's move our bodies now. We've eaten. If you're home and you're eating, close your plate down and let's get moving, all right? Get moving and find something that you love doing and stick to it. Where them fans at? Oh yeah, get them fans, all right? Because what exercise does for the body is it helps to control weight. And you know, the American Heart Association, the American Diabetes Association recommends that we move our bodies 150 minutes per week. That's 30 minutes of walking or cycling 5 days a week. That's only 30 minutes. But if you want to lose weight, then I say to you, let's progress it. Week 1, 30 minutes. Week 2, 45 minutes. And what we're doing in week 3, we're going up to 60 minutes, 5 days a week. And don't miss 2 consecutive days. But look at the benefits. It improves heart health and it decreases or prevents osteoporosis. Why? Because we got the muscle. The muscle protects the bone health. All right. And we're eating those dark leafy vegetables. We're getting calcium and vitamin D from that. And we need the vitamin D to help absorb the calcium we get in foods and the supplemental. And so resistance training, some of my colleagues talked about that. That helps, especially in women who are in menopause, 2 days, 3 days, 30 minutes, 20 to 30 minutes, 2 days a week. You can do 3 or 4 days, light weights, a lot of reps. You're going to build that skeletal muscle mass that we're losing from not having the estrogen. And so I'm going to close up soon, but I just wanted to touch on these micronutrients because I talked about micronutrients. Vitamin D, like I said, we need vitamin D. And some of us, if we're darker skinned like me, we don't absorb it from the sun. And so we need vitamin D, and that vitamin D is going to help absorb the calcium, not only from the foods we eat, we should take a supplemental vitamin calcium as well. All right. The magnesium. A lot of women say, do I need magnesium? Yes, we need it, but we can get it from the dark leafy vegetables. But it's they're finding that if you take it at night, it helps with moods, it helps to calm you, and it helps with sleep. Now, the black cohosh, one of my colleagues talked about this. There are no studies out, but women report some good results from it in relieving some of the hot flashes. And of course, I always recommend a probiotic. Why? Because it helps with gut health. It helps with regularizing your bowels, and it supports your hormone system. My colleague just before me, Dr. Hutchinson, she spoke about managing our stress and anxiety. And I like to think, I always like to take the negative and flip it. and make it positive. So stress have nothing on us, ladies, because we're going to flip it and say we're going to slow down. We are going to be anxious for nothing. All right? And when we slow down, we become still internally because we're going to breathe. That's the first food we eat is our breath. And Dr. Dorita knows when the baby comes out, if it's not breathing, all of us get anxious in that room, right? And so when we slow down and we breathe, we can think. So if we're anxious and stressed, we can think, okay, what is going on? You know, we could even say a little prayer. Then our resources come. We think of this one and the next one. Let me call him. Let me call her. We can evaluate those resources, whatever it is, to see if it works for us at this time. And then solutions come. Some of those resource persons bring us solutions. And then our support systems. My colleague just said, having support systems at this time in our lives is extremely important. It speaks to our spiritual wellness. It empowers us and restores us as women. Having good, solid people you can depend on is extremely important. Connect with people. Don't forsake your social lives. All right? And also, be careful with who you choose to bring into that circle of love as well. So at this stage, we could make choices that are full of wisdom. Why? Because we've earned it, right? So our faith beliefs are spiritual and prayer. And I'd like to just share this book. I found this book very inspirational. This is on Oprah's most recent list. And this lady, she is phenomenal. She's retired now. And I like her quote. I'm here to tell you that illness is not weakness. And when it comes to your health, silence is not golden, ever. Talk about it. The conversation started tonight, today. Speak up, see a doctor. And then I read this lady many, many years ago when I couldn't understand what was going on with me. And I started researching because I'm a researcher. And I came across her. I even had some coaching times with her on the telephone. She is phenomenal. And both those books are really good for women transitioning. We call them the menopause Bibles. And so I just want to thank you all for having me tonight. I want to thank my colleagues for helping me with this presentation because you took most of it. And so enjoy your dinner and have a good evening and God bless.
Wonderful. What a great reminder of the power that we have in managing our health with diet, exercise, lifestyle change, and mindset. So the power is within us. So participants, listeners, we have come to the end of our symposium. In the interest of time, we will not be able to do the question and answer period. But I assure you, like most of our speakers have said, this is just the beginning of what's to come and the beginning of the Renew Clinic. So I am now going to introduce you to Dr. Warner Rogers, who is the Executive Director of Outpatient Services and the arranger of tonight's symposium.
Good evening, everyone. Restore, empower, nurture, educate, wellness. We got all of that tonight. So I'm just happy that you are all able to share with us and to stay to the end. We are in the business of showing that menopause is a holistic approach to management, and we are here to help when you're going through that difficult transition in your stage of life. So on behalf of our president, Dr. Charles Digges, our chief medical officer, Dr. Antonio Colley, and all of the members of our executive leadership, I would like to thank you all for joining us tonight. Thank you to our August panel of specialists at the last minute, a few of them, thank you, for shedding so much light on a subject that long ago was taboo for all of us, So, and to those women who see themselves in some of the profiles shared tonight, feel free to check in on our website I'm sure instructions will be sent to you on how you can enroll for a consult in our Renew Clinic. So once again, thank you all and have a wonderful evening.